Good morning, everyone. And this one is the last lecture for urology. And this is about urological cancers. Now, the importance of this thing. As you have seen, my last two lectures were not so um, long. Why? Because those topics were more, you can say, internal medicine related. You guys have done that thing over there. So, and that's why I just talk about the surgical relevance of those topics. But other than urological trauma, some reconstructive surgeries, which are basically pediatric surgeries. Of course, like surgical or oncology or urologic oncology is a very important topic. Now, of course, urological cancers means all the cancers starting from the kidney, bladder, prostate, testes or ureters. Of course, like all this cancers will malignancies will come under this section. But of course, we are going to discuss the important ones. Um, if you can see, if you want to know the importance of these one, you can see the prostate is the most common cancer uh, in males, whereas the breast cancer carcinoma is the second, is the first most common in females. Other than that, if you can see over here, prostate is the most common one, then urinary bladder and the kidney and renal pelvis. Of course, there are other cancers which comes in between them, but we are doing urology, so we will be doing these three. So this one is, of course, you can see like estimated new cancer cases, 10 leading sites by gender, United States, 2000, and like these are the statistics of 2000. And you will see in the next photo, like these one is like, see, um, the same one. Okay, sorry, yes, this one. This one is the deaths. That's due to cancer. If you'll see over here, though the breast cancer and the prostate are the most common in women and men, respectively, but the mortality of these one are lower because the lung cancer, which is the second most common in both of the sexes, they have more mortality. So they, you can say like they kill more patients than these two cancers. And you will see like the urinary bladder comes way down. Okay, so this is just to tell you the importance of these cancers. So of course, like we are going to discuss mainly three carcinomas during this lecture. One is prostate, one is urinary bladder cancer, and the third one is kidneys. Now, um, I will start with um, renal cell carcinoma or kidney, renal tumors. Um, the thing is that, of course, like we will discuss the neoplasm, so we will not talk about the other ones. But you can see over here, renal neoplasms can be primary or secondary. Secondary being the metastatic, and renal cell cancer or renal cell carcinoma (RCC) represent 80 to 85% of the primary renal neoplasms. So that's make what you can say it as a important cancer to cover. But like this is, remember, this is not the most common one. So basically, renal cell carcinoma is a malignancy of the renal epithelium that can arise from any component of nephron. Okay. Then there is transitional cell carcinoma. Then there are some rare tumors like oncocytomas, collecting duct tumors, renal sarcomas, nephroblastoma, which is also called as Wilms tumor. Of course, like this is the most common one in children, most commonly present in children. And then there is renal medullary carcinoma. Let's start with renal cell carcinoma. Uh, Now, renal cell carcinoma basically represent 2% of overall cancer incidence and mortality. So, like you can say, among all the cancers, this one is not so common. But of course, uh, you can say like I have some data of United States, like in 2010, they have around 55,000 cases of renal cell carcinoma with 13,000 deaths. So, like this is how much common it is. So this one is like the figure, 50,000 cases diagnosed and 13,000 deaths annually in the US due to renal cell carcinoma. So 126% increase in incidence and 35% increase in annual mortality over the last 50 years. Uh, there are many things, many reasons behind that. One of the things is, industrialization, chemicals, and all this stuff. But okay, so all stages increase, but greatest increase in localized disease. 5-year survival has doubled since 1954, of course, because of better management available. So you can see over here, like this is again in 2001, it was taken from Urology Journal, rate per 100,000, how many people they have this thing in 1973 among the blacks, whites, and the mortality and the incidence. So this is the mortality and this is the incidence. So okay, it is slightly more common in males uh, than females, but the difference is not so much. And uh, basically, if you will see, like the incidence is higher in um, elder age group. Median age of diagnosis is 66 years of age. So highest incidence in Scandinavia and North America and lowest in Africa. So now, what are the risk factors for this one? Uh, Smoking, very important, and obesity, high blood pressure, long-term dialysis, uh, then von Hippel-Lindau syndrome. Not just this, like other than that, tuberous sclerosis and some of the people who have acquired cystic disease, they may have also occupation. Coke oven workers in the iron and steel industry are at risk, and workers exposed to asbestos and cadmium also may be at risk. And genders male are more likely than female to be diagnosed with kidney cancers, like as I told you. A little higher incidence is there. Okay, so this one, as I told you, we are going through renal cell carcinoma, and if you will see over here, they have given the types, right? Like it is adenocarcinoma, and it arises from proximal tubules most of the time. The spread is via extension, lymphatics, and hematogenous. So it spread to the lymph nodes, lungs, bone, and liver. So this is how it spreads. Now, um, the thing is that how it present. So basically, uh, though every patient have a different presentation, but what happens, like in this case, in renal cell carcinoma, what they say is like, if you can see over here, variety of symptoms, mostly asymptomatic. So whenever there is sign and symptoms, hematuria, flank pain, and weight loss. Okay, like this is a typical presentation. Uh, like okay, and one of the thing, like what is said is like anyone who have a flank pain with a mass and hematuria, always look for renal carcinoma. Okay, So classic triad, you can say flank pain, hematuria, and mass occur in 9, though like the patients who have what you can say, very few people have like these typical triad, but of course like they are very much point towards renal cell carcinoma. And 45% of the patients present with localized disease, 25% with locally advanced disease, 30% with metastatic disease. Again, guys, you don't have to remember the remember the numbers, what is written over here, but like this is to just to tell you, as I told you, not all the patients they present in the same way. Rather, there is what you can say variety of presentation ranging from asymptomatic to being symptomatic, and what kind of symptoms. Maybe someone just present with hematuria, maybe someone just present with flank pain, or maybe someone just present with a mass, uh, or mass with hematuria. So any type of these things, any one of these can be there. Okay, so there are many paraneoplastic syndromes, and I always stress out like when I teach lung carcinoma and I talk about paraneoplastic syndromes in details. Of course, like because uh, like now one of the thing, for example, many people they may present with anemia or hepatic dysfunction, hypercalcemia, caxian fever, and erythrocytosis. So why erythrocytosis? Because of the tumor, there is more erythropoietin formation, and when there is more erythropoietin formation, there is more red blood cells. So, so renal carcinoma basically is one of the malignancies for which paraneoplastic syndromes are there. So, like any one of these can be found. Okay. So one of the thing is, like of course, when there is erythrocytosis, so ESR come back as high. Okay. So now, um, before going to diagnosis, I would like to talk about that renal cell carcinoma have different types, for example, or varieties are there. There is clear cell carcinoma, there is papillary carcinoma, there is collecting duct carcinoma, there is medullary type. Okay, so like all these things, all these different things can be there. So how is the diagnosis is done? Of course, like this is one of the cancer for which there is no general screening is done in the general population. Okay, so too many like who won't understand this thing, basically in different countries they screen people for different cancers time by time. For example, females, they are screened for cervical cancer or breast cancer, or for males like there is screening for colon cancer. Even for females there is screening for colon cancer, but like renal cell carcinoma, because the incidence is not too much high, so the screening programs are not there. So basically what happens is uh, whenever the patients they present with symptoms, so they directly go for investigations. And what kind of investigations? Of course, uh, uh, ultrasound can be done, contrast CT scan can be done, MRI can be done, and this is just to catch the mass. And of course, not just this, like you can go for a CBC, LFTs, calcium levels, ESR, things like this. But of course, like the diagnostic test will be like this. And like for example, on ultrasound, maybe you will find a cyst or a solid mass. There is a system or classification system called as Bosniak classification system, on which uh, like they categorize either it's a simple cyst or either there is like what are the chances that like it could be a tumor. So of course, like once they found a tumor or a mass, they will go for a the doctor, like the physicians or the dealing medical personnel, they are going to go for a further diagnostic test. For example, in this case, what they will do, they are going to do a biopsy. Okay, so biopsy nowadays, of course, they can do it by uh, what you can say FNAB, like it's not an open biopsy, like they can put a needle, you can say, and they can take a small piece of the tumor to to study it or to see like what kind of cells are there, just to make the diagnosis. So of course, like the biopsy is going to make the diagnosis, and once the diagnosis is done, and of course like the biopsy can also be done by nephrectomy, in which of course they are going to excise the tumor and then they see what kind of cells are there. So you can see like the histology of a clear cell, 75 to 85% of renal cell carcinoma are clear cell. Rest I told you, there are other types as well. Okay, so of course, like whenever any patient is diagnosed with any type of cancer, we go for staging, and you can see over here TNM staging is used. Okay, and in TNM staging, T stands for tumor, N stands for nodal, nodes are involved or not, and M stands for metastasis. So we know like what are the most common sites of metastasis. It is lymph nodes, lungs, liver, bone, and brain. Okay, and up to 20 to 30% of the patients, they present with metastatic disease. So of course, like, or you can say stage 4 disease, but because see, there is no metastasis in any stage. Whenever there is metastasis, we call it a stage 4 disease. So simply, many of the patients when they present with stage 4 disease. Like around 20 to 30% of the patients, they present with stage 4 disease. Why? Because their cancer or their malignancy is already spread to other parts. So once the staging is done, okay, now this one is again like the explanation, like what is T1 when the tumor size is 7 centimeter or less, but limited to kidney, and T1A, T1B, and like all this is TNM staging, I think, which we have done many times before. So again, a very nice, you can say a diagram just to tell you the concept of staging. See, when the tumor is just located over here, it is stage 1, tumor less than 7 centimeter. Stage 2, tumor more than 7 centimeter. 5-year survival rate 88%. Stage 3, you can see this or this, tumor in major vein or adrenal gland. Okay, and 5-year survival rate is 59%. And stage 4 is this one or this one. Look, either tumor is beyond the fascia, which is covering the kidney, Girota's fascia, or it is involving the regional lymph node. So it is stage 4. 5-year survival is just 20%. 20% of the people, they survive for 5 years. So by this one, you can answer the prognosis as well. Otherwise, you can see the prognosis completely depends on the stage. If the stage is less, of course, the prognosis is more. If the stage is 4, the prognosis is less. And other prognostic indications include poor performance status, anemia, hypercalcemia, and elevated LDH. When they are present, of course, the prognosis is not so good. Okay. So how they treat? So again, I'm explaining you what is the diagnostic workup. We will go for imaging, we will go for biopsy. But what is staging workup? We will go for lymph node biopsy. We are going for CT scan. We are going to see CT scan head, chest, abdomen. We will go for PET scanning. Okay. So just to see like what is the spread of the tumor. Now how it is treated? Basically, renal cell carcinoma is a surgical disease. And surgical disease, like of course surgery should be done. So all the tumors which are diagnosed and there is no metastasis, or for example the metastasis is just in the lymph node, the best thing is to go for surgery. Okay, so see, radical nephrectomy is gold standard. Partial nephrectomy in selected patients, for example someone whose one kidney is already gone, so maybe half of the kidney for him to survive. No role for adjuvant therapy except under investigational protocol. 20 to 30% of patients relapse within 2 to 3 years. And metastasis of the lung is most common, 50%. Local recurrence rate is 2 to 3%. So Remember, it's a surgical disease. Once it is diagnosed, it should be removed surgically. So if the disease is advanced, like there is too much metastasis, so primary treatments are systemic therapy with molecular targeted therapy or immunotherapy. So surgery is palliative therapy in that case, and completely depends on the patient, like how much the spread is. For example, if the spread is too much, so of course we go for palliative therapy. Okay. Uh, Nowadays, of course, there is new advances and there is new drugs. Okay, so that's why uh, many of the drugs are prepared. So, for example, one of this thing is uh, like like the renal tumors are highly vascularized and there is vascular endothelial growth factor. So what they do, like they do vascular endothelial growth factor pathway inhibition. So for that, different drugs which are called as tyrosine kinase inhibitors are available. Sunitinib, sorafenib, they are very, very, very expensive. Monoclonal antibody that bind circulating VEGF receptors, they can be used, and these are all new drugs which can be used. So this is some of the explanation of sunitinib, sorafenib, and all these drugs. Like basically, it's none of your use, because what they talk about is like when they run some studies, so they gave placebo to some of the people and these drug to some of the people. So see, there is no difference in median survival. So these are the reports of that. But for you, like these new therapies are available. Immunotherapy can also be given in these patients. Okay, so you can see these are some photographs of radical nephrectomy. Okay, of course, to remove that, and partial nephrectomy, in which like they remove a part of the uh, kidney. So in simple words, it's a surgical disease. Whenever there is no metastasis or solitary, like one metastasis, of course surgery is the approach. And what they do, they remove that area. But nowadays we have new chemotherapeutic drugs, especially I told you about tyrosine kinase inhibitors, very expensive. Okay, but remember, like whenever the disease is extensive, then they go for palliative therapy, right? So and of course, like in selected patients, when one kidney is already gone and you have to save the kidney, then you will go for a partial nephrectomy. Of course, you have to save the kidney, like the rest of the kidney, for the patient to survive. So this is about uh, renal carcinoma or renal cell carcinoma, which is the most common one. Okay, this is how they do it. Now there are many other cancers of ureters or urothelial cancers, which can occur in ureters, but like they are not so important. So that's why we will jump on. Uh, like these are some real photographs, by the way, of nephrectomy. Okay, we will go for prostate cancer. Okay, prostate cancer is very important. Why? Because it is the most common uh, cancer in men. Okay, and one of the thing again, I forget to talk about the complications of surgery, guys. Remember, uh, I say in every lecture, the complications are somehow same. Like some general complications are there, which are somehow same for all the surgical procedures, right? Uh, uh, like uh, bleeding, hemorrhage, infection, damage to the joining structures. Okay, so like they are almost the same, right? But for example, whenever you are going to do like the surgeons, they do radical nephrectomy. Of course, they have to remove all the kidney and the joining structures. So of course there will be more bleeding. There could be pneumothorax. There could be splenic injury. There could be liver injury, depending on either they are operating on the right kidney or the left kidney. So, but or urine leak can, like in this case, kidney surgery. Of course, urine can leak. So the things are somehow same. Okay, so now comes the prostate cancer. So as I told you, it is the most common cancer or most common malignancy in males. Okay. Okay, so you can see, you have seen this one. Okay, it is the most common one. And of course, prostate carcinoma cannot occur in females, they don't have prostate. uh, One thing, by the way, they say like prostate cancer is the most common non-cutaneous malignancy. Okay, so this is important. You can see like the incidence of prostate with against the mortality. These are the countries, incidence and mortality. So now, prostate cancer, uh, what you can say, uh, many of the countries, or not countries, you can say like authorities, health authorities, they say like, or organizations, they say like there should be yearly screening of prostate carcinoma, like digital rectal examination can be done, or prostatic specific antigen PSA. If you have seen the lecture of benign prostatic hyperplasia, they can be done. So especially in those patients, who have like some family history, or African race, they have more incidence of prostate cancer. And anyone who have like a abnormal rectal digital examination, like digital rectal examination, or higher PSA level, so they must be like biopsy should be done in those patients. So nowadays, of course, it's quite easy. PSA can be done instead of DRE, right? Okay, so you can say like there are many risk factors. So the most common risk factor is age. Remember, it is a disease of old age. Like this malignancy is a malignancy of old age. Okay, it is so common that they say like many of the cancers, basically they are never diagnosed. Why? Because the patient, it's a very slow growing type of malignancy. So they do have prostate cancer, but they keep on living with that. And even with the management of prostate cancer, it is the same thing. Like they say this, they see like what is the life expectancy of the patient. So sometimes when the life expectancy is less, basically they don't treat it. So, but if you see, okay, the risk factors uh, of prostate cancer, like is age, like basically men who are more than 60 years of age. Okay, and African race, if you talk about the ethnic origin, family history, when someone already have in the family. There is some geographic variations as well, as you can see, like in different countries. Like I'm talking about this one, the USA highest one, and China lowest one, right? So India, Japan, like these areas, they have less, right? But if you see like the white race, see there is a lot of people who have prostate cancer, and lifetime risk is 1 in 8. Okay, so everyone is at risk of this thing. So many of the time, by the way, prostate cancer is diagnosed when they treat the patient for BPH. Okay, so you can see like less than 40, 1 in 10,000 risk, 40 to 59, 1 in 100 risk, and 60 to 79, 1 in 8 risk. So ethnic risk is given, African American, it is the highest one. In Japanese, it is the lowest one. Because it is very common, so that's why a lot of research is done in uh, this one, in this field. This is like according to the geographic variations. The family history explanation, anyone who have one relative, two relative, or three relatives. So someone who have three relatives with prostate cancer, see the risk is 11 times more. Very, very, very common. Okay, so again, this is like the presentation, and like this one, you have to understand it uh, in the light of the medical advancement. See, in 1950s, 28% were diagnosed when it was localized, and 72% was diagnosed when it is extensive or metastatic. But now, because we have a lot of very good diagnostic things available, and PSA test and all this thing, and awareness, good medical facilities. See, 80% localized are diagnosed with no symptoms, and 20%, of course, like when they are metastatic. Okay, so what they do, like they detect it by PSA or DRE. Okay, now the thing is, I am not going on clinical features. So maybe you are thinking, where are the clinical features? Okay, when there is prostate cancer, the patients basically present with what? Maybe they will present with like bowel outlet, bladder outlet obstruction, right? So most of the times, nowadays, because due to screening programs, it is diagnosed before any sign and symptoms. So that's why detection, as I told you, PSA can be done and DRE can be done. So PSA, see, it's like prostate specific antigen. It is serine protease bound and free forms are there, produced by prostate tissue and produced by benign and malignant cells. So of course, it is produced by benign and malignant cells, so it is not cancer specific. But whenever there is cancer, of course, the level are very high. So this is important to know. Whenever there is PSA is elevated, think about cancer, think about enlarged prostate, think about prostatitis, inflammation of prostate, or prostate infarct. So this thing. So now, as I told you, screening, I told you about this thing before. Like many of the countries, the screening programs are there. Basically, the newer guidelines is like this should be 45. They say like anyone who has family history or who is African American in America, they say like their screening should start at 45 years of age. So the symptoms, as I told you, whenever it is localized, no symptoms. Whenever it is locally extensive, like locally, but it is growing, think about BPH. Same features like BPH. And metastatic, of course, like depending on where the metastasis is, it is going to give the sign and symptoms regarding that one, like bone pains or whatever XYZ. So simply, uh, anyone who have abnormal DRE examination or abnormal PSA levels, go for a biopsy. So biopsy can be done by, you can see over here, by transrectal ultrasonographic biopsy. So they put ultrasound probe in the rectum and a needle. So the ultrasound guide the needle towards in the prostate. They take a small specimen and then they see it under the microscope. The pathologist, of course, it is adenocarcinoma spread by direct extension, lymphatics, hematogenous, found in peripheral zone, uh, opposed to what we were studying in BPH, which is in the central zone, right? Spread to seminal vesicles, lymph nodes, bone, lung, brain. Okay. A very important thing, Gleason score. Gleason score is very important because it is this Gleason scoring system is how it is graded. Okay. So basically the grade runs from 1 for the most differentiated to 5 for the least differentiated, right? So what they do, first of all, they grade it, and then there are basically, you can see over here, okay, so grading is done. Gleason score is used. Okay, so anyone who have 2 to 6 Gleason score, it is low grade, 7 intermediate, and 8 to 10 high. So now two things which we can see after biopsy. We can see like what kind of cells are there. Either they are well differentiated cells or poorly differentiated cells. So now what they do, like they take the grade from 2 areas and then they add it together. So 1 to 5. So when you will add these 2 grades, so the maximum can be 10 and the lowest can be 2. Okay. So, and one other thing, so see, one of the thing is biopsy, one of the thing is PSA levels, and the third thing is Gleason score. Based on that, they decide either it is high grade, either it is intermediate, either it is low grade. For example, uh, any Gleason score of 8 to 10, or when the PSA level is more than 20, it means that it is highly metastatic or very aggressive type of tumor, right? So this is how it is done. And then, of course, we go for staging. And this is like how staging is used. You can see stage 1, stage 2, stage 3, stage 4. And when this cancer is, of course, spread to other organs, it is stage 4. Okay, see, this is stage 1, tumor is small. Stage 2, tumor is bigger. Stage 3, it is like even bigger. And stage 4, of course, like you can see over here, this is explanation. T1 is doctor is unable to feel the tumor. 1A, 1B, 1C, and then T2, doctor can feel the tumor. T3, cancer has begun to spread outside the prostate. And T4 is like, of course, whenever there is any metastasis. So basically, the most common site for the prostate cancer to metastasize is pelvic lymph nodes and the bone. Okay, so anyone, well, of course, like when we will talk about, for example, investigations. What are the investigations? You have to do, first of all, diagnosis. You can do biopsy, you can do PSA, and diagnostic like metastatic workup, or for staging you have to do all the other staging workup, and based on that you can decide what is the grade on the biopsy, what are the PSA levels, what is the stage. Okay, and then you will of course go for the treatment. Okay, so talking about the treatment of prostate cancer is basically, you can see over here, there is nothing, watchful waiting, active surveillance, depending on the grade. There could be surgery, radical prostatectomy, in which like they remove the prostate. There is radiation, which can be external beam radiation therapy, which can be brachytherapy. And there are many hormones which can be used, like androgen ablation can be used, and other cryoablation and things like this are present. Okay, so what is done uh, in these patients is like anyone who have a localized disease, and they found like uh, it is curable locally, so of course like, and the patient medical status is good, so they are going to remove that tumor, right? So for, of course, like, but for example, one of the thing what is watchful waiting is okay, this is an overview for the tumor who is what is a T1 T2 stage. Surgery, radiation therapy with watchful waiting can be used. T3 T4, radiation plus hormones, and whenever there is metastasis or nodal involvement, hormones can be given. So what is watchful waiting uh, is when the disease is localized. Watchful waiting can be done depending on the score, or we can go for prostatectomy. Now prostatectomy or radical prostatectomy can be done via a laparoscopic way, by a open prostatectomy. Okay, things like this thing. But whenever the disease is advanced, if you will see over here, whenever the disease is advanced, we go for hormones. Okay, or we go for androgen ablation therapy. So generally what they use is LHRH agonist. LHRH is luteinizing hormone releasing hormone agonist. So this is the thing. So remember, you can say over here, watchful waiting for someone who have a low PSA, low grade, and low stage tumor, right? So that one, in that patients, they keep on doing biopsies, they keep on doing PSA levels, and keep on checking either the grade is increasing or not. But once like it is increasing or these things are there, then they will go for radical prostatectomy. Okay, and you can see over here, like radical prostatectomy means what? They are going to remove the seminal vesicles with all the prostate. Okay, so this is like how they do radical prostatectomy, like what they remove during radical prostatectomy. Okay, and the other therapies which are available, this is like retropubic approach, this one, and this is perineal approach to remove prostate. And then what they do, like after removing prostate, they do urethral bladder anastomosis. Of course, they have to connect the urethra with the bladder. You can see over here, like the prostate cancer removed. Okay, and now what can be the complications? See, again, hemorrhage, infection, damage to the adjoining structures like rectum, right? Rectal wall can be damaged, for example. Bladder can be damaged. So of course, like the complications are somehow same. One of the thing which I told you is uh, external beam radiotherapy. If you see over here, external beam radiotherapy can be used. This is a kind of radiotherapy, or brachytherapy can be used. Like nowadays they are available. Okay, and of course, like after that they keep on monitoring the patient. They see like either PSA is going down and the patient have show any signs of malignancy again. So all these things are can be done. So this is about prostate carcinoma, and after that there is one more carcinoma which we are going to cover. Basically is um bladder carcinoma, bladder cancer. As you have seen, like the bladder cancer is not so common. Okay, so when it is not so common, so of course like uh, it is not so important like prostate carcinoma. So you can see over here, um, 61,420 new cases and 1,360 cancer related deaths. Uh, Again, like uh, the slide, all the details are taken from one book. For like, and that book was American basically. So, second most common genitourinary malignancy in US, first in China, and male to female ratio slightly less than 3.3:1, one half as common in African Americans. So, uh, and two-thirds over the age of 65. It is very rare under the age of 30. Okay, so what is the etiology? The most common etiology in bladder carcinoma is occupational exposure to chemicals, cigarette smoking, analgesic use. In Africans, there is an infection called as schistosomiasis. In Africa, it is very common. Like, not very common, like, if we will compare it from the other regions, that is more common in Africa. Bladder calculi, pelvic irradiation, and chemotherapy. So, most commonly, it is transitional cell carcinoma, more than 90% of the times. Um, Squamous cell carcinoma is common in Egypt, you can see, and it occurs in the people who have schistosomiasis. Okay. Otherwise, the most common is transitional cell carcinoma. So now it spreads via direct extension lymphatics and hematogen. It spread to lymph nodes, lungs, bone, and liver. Okay, so you can see over here, 85% of the patients, they present with painless hematuria. Okay, they present with painless hematuria. So, by the way, the most common presentation, because even I know a few of the people who had this uh, 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 bladder cancer. They present with, like, they wake up in the morning, they went to the washroom, and when they pee, it was all bloody. Okay, and due to that tumor, there is basically irritation to the bladder, so they have the same symptoms. Again, think about the bladder symptoms, storage symptoms, and lower urinary tract obstruction symptoms, frequency, urgency, dysuria. So they can also present with flank pain, in which, like, when there is ureteric obstruction, or they can present with a pelvic mass. So again, like you can see over here, this is grading of papillary urothelial neoplasms defined by WHO. Not so important. Simply, whenever there is renal cell carcinoma, how we diagnose it, we can go for ultrasound, urine cytology, we can do a cystoscopy, intravenous urogram, CT MRI, okay, or transurethral. We can go and see like uh, what is the, we can take a biopsy, right, of that. So of course, like all this investigations can be done. Once the diagnosis is done by on biopsy, then we go for staging. Staging again, it is, you can see the staging over here, T&M staging, okay, the tumor size, what is T4, and this is like the T&M staging, and on the other hand, see Jivet stage, which is another way. So lymph nodes and biopsy, like it is the same. So again, a very nice uh, photo, you can say, which will tell you the classification. See, this is carcinoma in situ, then TA stage, tumor 1, tumor 2, tumor 3, tumor 4, T4, like when it is basically beyond the fatty layer of the, which is covering the bladder. So once the diagnosis is done, like if you can see over here, this is like the intravenous urography, and you can see all the contrast over here, but there is some filling defect. So this one is the filling defect on CT scan, right? So this one is the filling defect, or this one is the filling defect, you can see. Or you can see over here again, in the bladder, you can see the tumor easily. So now, how to manage? So the management basically depends on the stage. You can see the good when the tumor is small or low grade. So of course, TUR is basically trans-urethral resection. Okay, so the best thing is trans-urethral resection. Um, when it says multiple large or recurrent tumors or CIS, carcinoma in situ, in random biopsy, so consider intravesical chemotherapy by mitomycin C or immunotherapy. So this is how it is done. But when the tumor is, of course, like having high rate of progression, so then we can consider cystectomy, removing the bladder. So uh, this one is transurethral resection of the bladder tumor, TURBT. Okay. So this is see how through the urethra they are going to remove the tumor. Okay. And this is very important, as I told you, and I show you in diagnosis, it was written transurethral resection of bladder tumor. So this one is again like a very important thing to take out the tumor, to make the diagnosis, or to make us to get a specimen, so that you can see like what kind of tumor it is. Okay, so any tumor which is basically beyond the wall, muscle wall, of course, like, or you can say it is at uh, some advanced stage. So simply for stage 2 to T2 to 2 or T3, partial or radical cystectomy, radiotherapy or combination of both. And for stage 4, chemotherapy followed by radiation or surgery. And someone who have uh, diffuse carcinoma in situ, or like which is very much malignant, then intravesical chemotherapy, preferred primary treatment for CIS, and radiotherapy and chemotherapy. Okay, so this thing what it is done. So the thing is, when they do cystectomy, of course, what they do, they remove the bladder. So once they remove the bladder, so uh, what is done after that? They can connect the ureters with you can say they can take a small part of ileum. So this thing can be done. Whatever the urine is formed basically comes out from this one, and they attach a bag over here. One of the thing is Indiana pouch is created for some storage, and later on like taking out urine, or a new bladder can be formed. New bladder form can be formed. So this thing can be done. And remember, like anyone who have very much advanced disease, in that case, of course, what they go for palliative therapy. So, or like in that case, control the bleeding, uh, control the pain. For ureteric obstruction, hydronephrosis, of course, do a debulking surgery, things like this. So you can see over here, painful bony metastasis, radiotherapy. Palliative radiotherapy may also control local symptoms, and block catheter may be difficult to manage. So these things can be done. So okay, so okay, this one is like some real photographs, from the surgeries, like removing the tumor, doing nephrectomy. Okay, so I hope you understand this lecture, and this was the last lecture for urology. And thank you so much.